we'll start with Ryle's tube right now. So Ryle's tube is basic nasogastric tube insertion. So to any procedure, always there are some reasons why we have to do the procedure. Indications for the procedures, obviously very few basic indications being that if patient is presenting with any kind of obstruction, so in that case you have to insert a Ryle's tube to aspirate the stomach contents. Apart from that, you must have read in forensic medicine that in case of any poison ingestion, that you have to insert a Ryle's tube so as to aspirate the poison contents out. And then there are a lot of indications that is there in the textbook. Let's proceed with the procedure, what they are doing. So obviously, whenever you are inserting anything into a person's body, you should make sure that the entire process is sterile. So that is what the importance is, to wear a sterile glove. Okay, so now coming to this part, how do you, like in a Ryle's tube, for Ryle's tube insertion, there are several markings. So each and every individual is different, right? So we have to decide till how much length we have to insert the Ryle's tube. So for that, the basic measurement is that you have to go from the nose to ear and from ear to the xiphoid. That is how you measure what is the exact length of a Ryle's tube that you need to insert. So after knowing this length, then we'll see how to proceed with the procedure. They have determined what the length of the Ryle's tube needs to be. Down to the xiphoid process from the earlobe. So this marking is there for 60 centimeter. After knowing the exact marking, this is a lidocaine jelly. You have to take the lidocaine jelly in your hands first, and please note that he is doing it in the most sterile way possible. That the Ryle's tube is not touching the patient, because the Ryle's tube is sterile and you are entering into someone's body, so that needs to be sterile to prevent any kind of infection from the external to the internal. So after taking the gloves and after taking the Ryle's tube measurements, he first puts jelly on his hand, and in the sterile way he takes the jelly on the Ryle's tube. This jelly helps in lubricating the passage as well as anesthetizing the passage, because this is lidocaine. This is a local anesthetic. So on inserting the Ryle's tube, the first, like when you insert it through the nose, you are going to feel a resistance at the first. You are comfortable in English, right? So you will feel a resistance at first. You have to overcome the resistance and push it slightly, not too much, but slightly you have to push it, and then it goes down the throat. And once you reach the marking, that is the 60 centimeter mark, 60 marking is there. Once you reach it, that is when it is confirmed that it is inside. Now you have to confirm whether it is inside the stomach or it has gone into the lungs. How do you confirm that? There are two ways of confirming that. One is aspiration of stomach contents onto the Ryle's tube. You will see stomach secretions coming onto the Ryle's tube. That is one. And two will be you have to take a 10 cc syringe and fill air in it, fully with air in it, and then you have to put the stethoscope on the xiphoid and press it, on the epigastrium, and you have to press the 10 centimeter of air. And you will hear a whish sound, like a hush sound in the stethoscope. That is how you confirm that it is in the right position, that is in the stomach. And to ease the process, you can always give the patient a cap of water and ask him to swallow that little bit of water, so that can aid in the process of insertion. Now the marking has been reached, that is 60 centimeter. Obviously, even after inserting the Ryle's tube, a lot of times what happens is it coils up inside the mouth, because there is a common passage from the nose and the mouth. There is a common passage here, so a lot of times it coils up inside the mouth. You have to ask the patient to open up the mouth, and you can see the coil of Ryle's tube inside the mouth. That is when you have to take it out again and try it again. So the 60 centimeter has been reached, and now keeping the stethoscope at the epigastrium, and a whoosh sound will be heard in the stethoscope that will confirm the presence of the Ryle's tube in the stomach or stomach contents coming onto the Ryle's tube. Then you fix the Ryle's tube. So this is about the Ryle's tube in the sense that the basic procedure. So now Ryle's tube comes in different sizes. So do you guys know what is the basic unit for measurement of a Ryle's tube? You must have heard about French, 12 French, 14 French, 16 French. So Ryle's tube comes in different measurements, that is being 12 French or 14 French, 16 French, depending upon what kind of patient you are catering to. Like if there is a pediatric patient, then obviously you cannot insert an adult Ryle's tube onto the patient. So in such cases, you have to choose a smaller length Ryle's tube, that is a 8 number or a 10 number or 12 number. The French is basically the inner diameter is noted in terms of French in Ryle's tube. Do you have any questions? Also, xiphoid process. Ideally, it should be sterile, but that is how they measure it. When you are asked, you should always say that we need to do it in the most sterile way possible, like that. And also the tip of the Ryle's tube, if you see, there is a radio-opaque material on the tip. So in case you still have a doubt, even after doing all these maneuvers, you can still go for an X-ray. And the X-ray will show the presence of the tip in the stomach, and that will confirm the presence of the Ryle's tube in the stomach. Any questions? We discussed about Ryle's tube right now. Ryle's tube is, I'll give you in short that it is nasogastric aspiration. It is done in a lot of cases. There are a lot of indications to insert a Ryle's tube. The basic measurement for Ryle's tube is from nose to ear lobule to the xiphoid process, and then you have to insert it. I'll just show you and you can discuss later on. This is not necessary, but the best way to insert a Ryle's tube is the patient being in sleeping position, the supine position. But you can also do it with the patient sitting and head extended. This is a measurement of the Ryle's tube. 60 centimeter needs to be inserted. See, again, you don't need to touch the nostril, right, to take the measurement. You can just take the measurement from above and not actually touching the thing for the measurement. So, there will be an initial resistance when you insert the tube. Slightly rotate the tube and try to maneuver it inside the esophagus. Look inside the mouth to just see if the tube has coiled or not. But obviously, if you get the air bubble or you get the whoosh sound, that confirms. You need not check into the mouth again to see whether it has. After insertion, you are supposed to push air to confirm whether it is in position or not. When you push air and you keep the stethoscope on the epigastrium. So this is about the Ryle's tube. Anybody has any question regarding Ryle's tube? Like this is a very basic understanding about the Ryle's tube. Should we proceed on to the next topic? We'll go with catheterization, urinary catheterization. Okay. Yes. No, no. So, like you know that if you take anything, if you swallow any liquid very rapidly and it touches the posterior pharynx, you will get a gag reflex, right? So, in these cases also, you might encounter gag reflex where the patient wants to spit out. So, in that case, this lidocaine helps because lidocaine goes along anesthetizing the passage. Huh? Yeah. But you're at the same time you're giving. Also, you can take a lidocaine spray and spray in the posterior pharynx to aid the process, but that is not usually practiced. Anything else? We'll proceed on to urinary catheterization. So, do you guys have any knowledge about why do we do Foley's or catheterization? Anyone? Pass urine. Okay. That is not able to pass urine, micturate and immobile patients. Okay. Anyone else? But okay. Matlab, if the patient is not able to micturate before the surgery, otherwise we ask the patient to go and void and come like that for that. Anything else? Okay. So for SPC, you have to be the most sterile way possible because this is a very common route for entry to infection. So in this case, you have to gather all the equipments before you perform the procedure. Okay. So now let's start with the procedure in the sense that the external urethral meatus is a dirty area because it is coming in contact with the urine. So first you have to make the area sterile. How do you do it? You take the Betadine scrub, you scrub the area, make that area sterile first. Okay, then you wear a gloves, and then you make sure that there is lidocaine jelly, the Foley's catheter, and a 10 cc syringe filled with saline or distilled water. These three things are a must for doing catheterization. Okay, after taking all the stuff, we'll go ahead with the procedure and I'll tell you along the way. Okay. All this is done in the US, not practiced here. So, all this is not needed in any case. Yes, the preparation part. You have to make the area sterile fully and make sure that the groin is also, you make it sterile. And then after covering it with a cut sheet, you wear gloves. So there are two ways to go about putting the Foley's. You can either take the lidocaine jelly comes with a inserter, that there is a nozzle to insert the jelly. You can directly insert it into the meatus, push a little jelly and then proceed with the catheter. One that is the process, and the second process is the way we did Ryle's tube. You take the Foley's catheter, take some jelly in your hand, rub the Foley's catheter with the jelly on your hand and then insert it. So in this process, what they are doing is they are inserting the local anesthetic into the meatus to anesthetize the passage and lubricate it for easy insertion of the Foley's. And any kind of resistance felt here has to be dealt very in the most delicate way because urethral injury is very common when you push a catheter into the urethra. So you want to avoid urethral injury at all costs. So after inserting the catheter fully, there's a balloon that is inside at the tip of the catheter. There is a small balloon that helps keep it in position. So this, the other white tube that you see, in that we insert 10 cc of normal saline that helps in inflating the balloon and it helps keep the catheter in position. So even if you try to pull it, it will not come out. This is what they will be doing. And then you gently retract it to see whether it is coming out or not. This means the balloon is fully inflated and the catheter is going to be in place. And then you attach it to the bag, Euro bag. So this is about Foley's catheterization. Any questions about this? How do you get to know if you've injured the urethra? Anybody? If supposedly you force push the catheter and you injured the urethra, so how do you get to know? Huh? Exactly. When you see any kind of blood in the Euro bag, you should suspect that maybe you've inserted into the urethra. In like another question for you guys, it is little into anatomy. If you are facing a difficult catheterization, like the catheter is not being able to push very easily, one is obviously wrong insertion into the urethra. Second can be what? Yes, enlarged prostate. In that case also you will find difficult instrumentation of the urethra. Okay. Any other questions? You have to deflate the balloon. So the same thing, the white tube that you see is a negative suction tube. So when you put the filled syringe, you have to push it. But when you put an empty syringe, it will just automatically draw the water. Or you just simply draw the 10 cc, the balloon will deflate and you will be able to retract the catheter. So again, this is also the sizing of the catheter is also again based on French. Just the same like Ryle's tube. That is also the diameter of the inner tube is mentioned in French, and depending upon the age of the patient, you have to choose the catheter accordingly. Like in case of pediatric population, you have to go from 4, 6, 8, and in adults you can go up to 16, 18 French. So in an emergency, a patient came, okay, and you are the intern over there, and you are being asked to catheterize the patient, and you are not able to catheterize. What do you think? Like you've given it a try, you've called your senior, everyone has given a try to catheterize, and you're not able to catheterize, and you do not want to injure the urethra. What do you think happens next? Do you have any idea that in case catheterization is not possible, what is the next step? Suprapubic catheterization. Aspiration is a temporary resort, but the same thing you can catheterize through the suprapubic way. So basically you are puncturing the bladder and taking the suprapubic way into the bladder, not going through the urethra. So next we'll go to SPC, understand when you're not able to, or there are certain indications such as the patient is already presenting with a urethral injury. In such cases, do not go for catheterization. We have to go for suprapubic catheterization. Same in females and males. In females, the urethra is positioned differently. Just that with understanding, you'll with doing the practical process, you'll understand how to do it. But the same process, same thing. You have to take the jelly and insert it. See, as you can see, the patient's bladder is full. Also, in cases of diabetic neuropathy, a lot of time patient presents with a bladder that is he is not able to void, and also in case of severe prostate cancers where the catheterization is not going to be possible. In such cases, you have to go for suprapubic catheterization. So in this case, because you have to make a small nick in the skin, you have to first inject the skin with a local anesthetic. This is what they are doing. They are injecting the skin with a local anesthetic. just above the symphysis pubis. Make a small nick to the skin. And then you can take a spinal needle and insert it perpendicularly to see if the position is correct, because when you insert it and you aspirate and you get urine, that means that the bladder is there just underneath. So this is a spinal needle. হ্যাঁ বলুন। হ্যাঁ আমি একটু পরে করবো, ক্লাসেই আছি আমি, আমাদেরই ক্লাস নিচ্ছি। ঠিক আছে, ঠিক। হ্যাঁ। So this is the dilator. A dilator is used to dilate the passage that can facilitate easy use. And after inserting the dilator, you insert the catheter and inflate the catheter in the same way. Yeah. No, the tract usually heals up, and even after removing the catheter, you have to stitch it. That is after removal of the catheter. So this is about SPC. Anybody has any question regarding SPC? Huh. Whether it is, they inserted the needle to check for the presence of urine, because this is a blind procedure. You're not doing it under USG guidance, right? So you have to be sure. Once you insert, let's say that you inserted it instead of the suprapubic, you are doing it in the umbilicus. So in that case, you can go on to the bowel loops, right? So in that case, what they are doing it, after making a small leak, they first insert the spinal needle to check whether the bladder is inflated and you're in the right position or not. Only after that, through that tract, they insert a dilator, so that you're sure that you don't injure any kind of bowel loops. What other procedures, like any other thing you guys want to know about? You guys are just starting final year, right? I also joined from today itself. Like today is my first day of, so I'll be taking your class on 21st, the lecture class. What time is it from? 10 o'clock. No? Friday, हाँ. That's 10 to 11. हाँ. और क्या प्रोसीजर? हाँ. छुट्टी. नेक्स्ट वीक, हाँ नेक्स्ट वीक छुट्टी है. अभी और क्या सीखना है? अभी और कौन सा प्रोसीडियर? राइट. हाँ. क्या बोल रहे हैं? 14 को होली है. नेक्स्ट वीक तो होली है, छुट्टी है. 21st को क्लास है मेरा. हाँ. राइट. तो शॉर्ट केस, यू गाइस वांट टू डिस्कस अबाउट शॉर्ट केसेस? हाँ. That is what I was told to take class on procedures. तो I ठीक है. तो और प्रोसीडियर, एनी प्रोसीडियर? ठीक है. राइस ट्यूब, then you know short cases next week. छुट्टी. कितने बजे तक क्लास होता है? दास है क्या? दास है किसी के पास? दास या कोई भी क्लिनिकल बुक है? ML शाह या कोई दास कैरी कर रहा है?